We are live.
A very good evening, everyone. Welcome to iFocus Online Lecture 221, number 8 from our series on Squint and Paediatric Ophthalmology. Today we have with us Dr. Savleen Kaur from PGI Chandigarh talking to us on sensory science and binocular adaptations in Strabismus. I invite Dr. Pradeep Sharma sir to welcome her and introduce our speaker.
Thank you, Dr. Shefali. It's really a pleasure to have Dr. Savleen, a gifted speaker, to talk on a topic like sensory science and binocular adaptations in strabismus. She's currently working as an assistant professor in the Department of Ophthalmology, PGI Chandigarh. She had completed her training in ophthalmology from MAMC New Delhi, and then she has had a fellow ICO visiting fellowship at Julestein Eye Institute, University of California. Special interest in pediatric ophthalmology always, and she's a member of WSPOS and has 70 index papers with 30 invited speaker sessions. And we are going to have a very lively session with her, although it's a theoretical topic, but it will make us all understand when Savleen speaks. So over to Savleen.
And welcome Dr. Amitava, sir. He has also joined just now. Hi, sir.
Yes, sir. Good evening.
Thank you, sir. A very good evening to everyone. Thank you, Dr. Santosh Shunawar, for having me here, and Dr. Pradeep Sharma, sir, for putting up this amazing lecture series on strabismus. Good evening, Dr. Amitava. So now I'm going to right away start with the topic. As a junior resident, I am admitting that I used to find this topic very, very theoretical and difficult to understand at some times. So I'll just be trying to make it a little simple and try to go a little slow to understand what are the sensory signs and why do we actually need to learn about binocular vision when we are talking about a patient not only of strabismus, but I think any disorder of the eye, particularly the retina also. So when we're talking about binocular vision, binocular visual development occurs to improve monocular vision. So in humans, primarily nearly 70% of the cells in the cortex are getting binocular signals. There are binocular cells which are responding to stimulation of either of the eye, in addition to the monocular cells that respond to stimulation of only one eye. As humans, we have the advantage of a large field of binocular vision as compared to, say, lower animals who need to turn their head. So as you see in this animation like Mr. Bean is doing, we actually don't need to turn towards the object that we are trying to see. Humans have this large binocular field of vision, and as compared to animals, say birds, which have like a tubular kind of vision because they need to turn their eye to look. In addition to this large field of vision, we also have this vision as stereoscopic. So we have the additional advantage that it's a large field of view and we are able to use two eyes simultaneously. Now, in order to have a binocular vision development, we need to have three very important things: a clear retinal image for that abnormal retina, equal image clarity from the two retinae of the two eyes, and the third most important being proper eye alignment, that is no strabismus. So when we are talking about binocular adaptations, what do we mean by them? It's a defense mechanism of the eye. Any developmental change that is occurring in response to an abnormal stimulation, a stimulation being which is trying to give us a blurred retinal image or a stimulation that is trying to make our eye strabismic, these kind of stimulations will make the eye adapt to them by offering a defense mechanisms, which we are now calling as sensory adaptations. In order to understand, we need to know how these adaptations develop, because these adaptations, they will develop depending on when the abnormal visual stimulation occurred, why it occurred, and the type of disruption, and of course, how severe it caused an insult and at what age. Just simplifying it, if I want to look at an image, say example, an image of a house, I am not using one eye to see it. What is happening is that we are having two eyes and we are forming two images by the two eyes, but we are perceiving them as one. So if the eyes are properly aligned, these two images from the two eyes will be the same size, the same illumination, and the same color. So if we have two images which are exactly the same and they are formed by the two retinae which are exactly normal, the brain will interpret it as one. So this normal binocular vision is the integration of these retinal images from the two eyes into a single one-dimensional visual percept and giving it a three-dimensional aspect as well. Now, how do we have this binocular vision? There are a lot of concepts that we come across in the textbooks, and we need to understand a few points before we understand how we are actually looking binocularly. Now, the first most important point that we need to understand is the concept of corresponding retinal points. Now, it seems a little bit logical that two retinae, two fovea, and then 2 points corresponding in every eye. So just for an instance, this point A, if I want to look at something on point A, then there is an image being formed in right eye and an image being formed in the left eye, and one single point on the retina is giving that signal to the brain. So retinal areas from each eye that project to the same cortical binocular cells are known as the corresponding retinal points. Similarly, if I want to look at an image B, this object is also forming one image in one eye and a corresponding point is being stimulated in the other eye. So these 2 points stimulate the same cortical binocular cells. So we get the same sense of visual direction from that object particularly. So these 2 points share a common relative visual direction. So we know this is the same object being imaged by 2 eyes. So the applied aspect is that although we have 2 images, we have 2 eyes, but we are still perceiving it binocularly single. In order to just overview it and just sum it up, what is a corresponding retinal point? If I may ask all of you, if we look at the screen that you are looking at right now, maybe on your mobile or your PC, if you look at your screen and then you try to put a little bit of pressure on the lateral canthus of your eye, so you see the screen is kind of getting displaced. You can use either of your hand, just try to displace the retina, the peripheral retina of one eye lightly. You can see how a small movement, a small nudge that you try to give on the sclera of one eye and how this image appears double. So we need to have 2 points in the 2 eyes which are stimulating the same binocular cells so that we get one image of the 2 images which are actually being formed by the eye. Again, if it is a little confusing, if we try to press one eye from one side, we see that this image is getting displaced. So we are making the 2 corresponding points not overlap with one another. After we have understood what are the corresponding retinal points, it was earlier believed that there is a circle passing through these corresponding retinal points and through the optical center, and any point lying on this circle would be seen as single. This is known as the Wieth-Muller circle. So a circle passing through the fixation point and the optical center is known as the Wieth-Muller circle. But now experiments have told us that a locus of all points which project to the corresponding retinal points is actually not a circle, but an ellipse. So any point on this ellipse would correspond to the same retinal points and form one image. Objects in front of this line or beyond this line will project to non-corresponding retinal points. So this ellipse, this line is known as the empirical horopter. So 2 points again, the Wieth-Muller circle, which is like a circle passing through the fixation point and optical center, and the empirical horopter, which is a locus of point which projects to the corresponding retinal points. So any object which is on this horopter, on this ellipse, would be perceived as coming from one visual direction. And if you go beyond that horopter or before this horopter, you will perceive it as double or not on that corresponding point. There is also a finite area around this horopter that is known as the Panem's fusional area. So in day-to-day life, if we apply it, if I'm looking at, say, point A, say I'm looking at the screen right now, anything other than the screen of my PC would be perceived as double. So that will be very confusing because we're living in a world which is constantly moving. So what adaptation, a natural adaptation that our brain has is that we have an area around this point where a little bit of disparity also is not seen as double, but is actually perceived as single. So this area, which is known as the Panam's fusional area, is actually an area in front and behind the horopter where objects stimulate. Non-corresponding points also are seen as single. So if I'm looking at my PC right now, in the room, there might be other things which are not perceived as double, but beyond and just before, they are perceived as single and maybe ignored by the brain so that I can fixate on my PC at that time. So object lying in front and behind will stimulate non-corresponding points, but they are within the Panam's fusional area, so they will still produce a stereoscopic vision. Now, if we talk about this in a visual space, this Panam's fusional area in the center is narrow because the foveae are being stimulated, so it is high resolution as larger fields, and as we go towards our periphery, this area becomes more wide, has lesser resolution, has smaller receptive fields and resolution. So what happens is, when our fovea is stimulated, naturally we have the highest resolution, and when we see something in the periphery simultaneously, the reception goes a little down. So if I turn my head to look at something other than my PC, that will be the point of vision because that will where the fovea is fixated. So that will be the point of highest resolution. And then other peripheral things will have a lower resolution than the one stimulating the fovea. So if we have understood the corresponding retinal points, we have a clinical application of this point because farther apart the two eyes are, say in a certain ethnic group of patients that we see, you'll see greater stereoscopic potential with greater IPDs of the patient. Also, if you have a closer object, the relative separation of eyes is more, so you will naturally have a greater stereopsis at near and a lesser stereopsis at distance. After we have understood what is the empirical horopter and the Panam's fusional area, we also need to understand that despite having to see a lot of things at the same place at the same time, we still do not see diplopia in a normal day-to-day life. So this Panam's fusional area that we see is like this, is shaped like around the ellipse, center, it is shallow and broader in the periphery. So anything beyond this fusional area will be naturally also perceived as double. So if we have to understand this, again, I would want you all to do a little experiment. Say if I'm looking at my PC, I put one finger in front of my eye, both eyes, and now I try to fixate at this finger. When I'm fixating at this finger, or maybe you can take a pen, if I'm fixating at this finger, my PC goes a little double. And if I'm trying to fixate at my PC and keeping my finger in front of my eyes, between the PC and my eyes, I start seeing my finger as double. So once again, try looking at your screen and at the same time, try to add one finger in front of your eyes and try fixating at the PC. So once you are looking at the screen, this finger is going to appear double. Try closing one eye. If you close one eye, you will observe that one of the images, the two images of the finger that you see, go away. You still concentrate on the computer or the screen and try to look at the finger as well. You're fixating on the screen and this double image of the finger that is formed is disappearing once I'm closing one eye. This finger is between the PC and me. So if I have the horopter, I'm trying to fixate at the screen. So the screen is lying on the horopter. And if I place something between the horopter and my eye, that is my finger, I start seeing it as double. So this finger, because it's lying before the horopter, is actually causing a cross diplopia to me. So objects nearer to the horopter will stimulate the temporal retina and hence cause a cross diplopia, and vice versa if I. So what happens if none of this is happening? We know that we need two structurally normal maculae that can form two images in the brain, and the brain perceives them as one. We also understand that there is an area beyond every object that we see. The clarity can be controlled by the brain and fused into one. What if the eyes are not aligned properly? So that is what we know as sensory adaptations, and that is what we need to understand before we talk about management of a patient with strabismus. When we talk about these defense mechanisms or the adaptations that the eye have, these adaptations could be in the visually mature system and could be seen in a visually immature system.
Sorry to
By
interrupt,
visually
ma'am.
mature
Ma'am,
system,
your
we
voice is
understand that.
breaking.
Yes.
Ma'am, your voice is breaking, ma'am.
Am I audible right now?
Yes, ma'am. Maybe like if you can turn off the video, then probably the audio will go smoothly. If you can try that, ma'am.
Okay, I'll just do that. I'll just stop sharing for a minute.
Sure, ma'am.
Now, can you hear me properly?
Yes, ma'am, for now. Yeah. We'll let you know, ma'am. It's going perfectly fine.
Thank you. So, when we talk about a visually mature system, we mean that a patient who is beyond, say, 9 to 10 years of age has had a structurally normal retina, has a normal macula for that age group of 9 to 10 years, and then has an insult that the eyes get misaligned. So this visually mature system can respond by three main mechanisms, that is diplopia, confusion, and retinal rivalry. So what do we mean by these two terms, that is diplopia and confusion? A simultaneous perception of two images of the same object falling on non-corresponding retinal points is diplopia. You see that I have highlighted two things, that is one same object and its corresponding non-corresponding retinal points. By confusion, we mean that is appreciation of two superimposed images that are stimulating corresponding retinal points, but they are two objects. So again, to explain it a little better, when we see two images of the same object, because they are stimulating non-corresponding retinal points. So if we look at this house and we look at this eye, which is turned inwards. So this is the patient of right esotropia, and this left eye is normally aligned. So you see that this house is being, the same object is seen by two different points in the two eyes. So we see that this object is seen as double. So we perceive it as a double because there are two images of the same object because they are not stimulating the same point. On the other hand, if we have two objects which are stimulating they are stimulating the same points but by different images. So we'll see two objects by the two eyes. The single object causing two images is diplopia, and two objects causing an overlapping of two images is known as confusion. So what practically, if you want to know what is diplopia and what is confusion, diplopia is kind of the most common adaptation that adult mature visual system will show, and kind of suppress one image so that we are seeing two images. We'll suppress the fovea of one eye. So in patients who have restricted fields, for example, in patients who have very advanced glaucoma or who have tunnel vision, so they will not be able to suppress the fovea of one eye because their field itself is restricted. Those are those few instances where they might see, because they are not able to suppress the fovea, so they might see two dissimilar images causing confusion in the eye. Again, when we talk about physiological diplopia, we know that we have seen that the horopter is what is the main focus of the visual direction. So when we have a esotropia in one eye, we have to remember that it will cause an uncrossed diplopia. So why does that happen? So when we have an eye, say the right eye of this patient is normal and there is an esotropia in the left eye. So this image will fall on the nasal retina that will project temporally. So that's why in esotropia, you will have the impression that there's another image on the same side. So to understand and to learn, simplify, means uncrossed, and exotropia, that is X, will give you a cross diplopia. So this is how an exotropic patient will see. You see, this is an eye with exotropia. So it will give you an impression that this particular object is lying over here on the cross direction because the eye is turned outwards. So exo, X for exo and X for cross. That is how you remember it. Again, just reiterating, an uncrossed diplopia, this patient has a right esotropia. So once the eye is turned inside, the normal fovea is lying somewhere here. So it is giving an impression that the image is falling somewhere here. So you see two images and this being corresponding to the same side. So same side, that is uncrossed diplopia, and cross diplopia because the image is seen on the opposite side. Remember, we are talking about fields and then we are talking about retinae. So temporal retina will stimulate the nasal field and the nasal retina will stimulate the temporal field. So once you have understood it, you might as well learn that uncrossed is in ESO and crossed is in EXO. The third adaptations that we need to understand is retinal rivalry. I hope my voice is clear now.
Yes, ma'am, it's clear.
Okay. So by retinal rivalry, once we have understood diplopia and confusion, it's different images which are projecting to the central field in a mature system. So what happens is, say, if you keep a distance of 2 inches from the eye and you try to keep, say, a pen or one finger in front of one eye and the other finger in front of the other eye, you'll see that both the images are fighting to reach the brain. So when seen stereoscopically, you'll see that you don't see a plus, okay, when you keep it like that, but you see a changing pattern. So if you have this kind of an image projected, one object to one eye, the other object to the other eye, which are very, very dissimilar, the brain will not be able to fuse them, but both the objects will try to fight for the image in the eye. And you'll see a patchy dropout, and you'll see sometimes in a bifoveal of obviously fixation which is normal, macula that is normal, and the two eyes are not misaligned. So that is how you are going to interpret it as a crisscross pattern, because both the objects are trying to fight to form the images on the retina. So 3 adaptations that a mature visual system has, that is diplopia, confusion, and then retinal rivalry. So retinal rivalry in day-to-day life, we might not see in patients because it's kind of excitation of corresponding retinal areas by dissimilar fusion, which happens very rarely. And sometimes it is manifest because of dominance of one eye over the other. So it is one mechanism, but yes, the least common of the 3 seen. So once we have a visually immature system, by immature we mean you have an insult in a very small child, the visual system, the binocular system has still not developed. So how will that system adapt to, or how will that system show a defense mechanism to any insult that is a misalignment of the eye? So when binocularity is disrupted in the first few weeks of life, especially before say 8 to 10 years, the visual system is still immature. And there are a lot of ways where the system will adapt, and these children, when they come to you as adults, they'll still have these adaptations which we have to pick up on binocular testing. So a visually immature system will have suppression, monofixation, amblyopia, anomalous retinal correspondence, and a large regional suppression sometimes. So 2 of these topics, amblyopia and anomalous retinal correspondence, will be covered in much more detail in the future lectures, but I'll just go through all of them a little bit.
Dr. Savleen? I think
I've lost connection.
Connection.
Pradeep sir, would you like to continue the discussion till Savleen ma'am comes back?
Okay.
I'll cross-check with Savleen ma'am.
Check with it. So basically till now, I think Dr. Savleen has tried to explain what happens if there is a misalignment in a mature system. And what we have is the bugbears of misalignment that will be in the form of diplopia or confusion. And then she is also going on to tell us how we adapt to them. And in the adaptation process, we have one is the retinal rivalry, which is taking care of the confusion. Confusion is happening because the two foveas in a misalignment situation is going to have two different images. That's what she explained, right? So whenever you have a misalignment and the two foveas are now going to receive two different images, it will give rise to a confusion. Whenever we have more than one options, there is confusion. If you go for a party and you have just one dress to wear, there is no confusion. But if you have two dresses to wear, you are confused which one to wear, the pink one or the blue one or whatever. So confusion comes with two options. And how do we take care of it? The brain is very smart because of the retinal rivalry or the cortical rivalry. It automatically decides that one image has to be used for that each area. And as Dr. Savleen had shown you with that simulation, if there are two crisscross lines which are there, the brain will see patches of it in a mosaic form. So that was one part of it. Second adaptation which can happen is for the diplopia. And what is diplopia? When the two non-corresponding or the disparate points are going to receive the same image. So that will be projected in the space in the opposite fields. And that's why she was showing that it will give rise to a diplopia. And diplopia will be taken care of by either suppression or an anomalous retinal correspondence. So Dr. Singh, I think, is back. So she can carry on with it.
Sorry, it actually started raining here. So I thought maybe that is the reason.
Is it okay? Yeah, you can share your screen. So I think she will take over and now explain to you how the adaptations are happening for these bugbears that we were talking about. Yeah, can you share?
Yes. I'm so sorry. I think I missed the last slide. I never knew that I got dropped out.
No problem, we can share
Go
again.
back to that, yeah.
So we are talking about the visually image. Sorry.
Yeah, ma'am. Go ahead. Ma'am. Yes.
So we're talking about a visually immature system here. Now, when you have a child where binocularity is still not developed and there is an insult that is causing, a strabismus in the eye, especially before 8 to 10 years, there are a lot of visually adaptations that occur in a visually immature system. So the first one is suppression. It's an English word. So suppression means just inhibition. The brain is inhibiting any disparate or any confusing image, but it will always happen when the binocular vision is being developed. So it will not happen if you have a monocularly seeing patient. Large angle deviation, which is constant and which is seen from childhood, the brain might suppress one eye, so inhibit it, and hence you'll see just one eye being used. So suppression could be central or peripheral. By central suppression, we mean that in order to avoid confusion, we are just suppressing the image of the deviating eye. And by peripheral suppression, we mean that preventing the awareness of image that falls on the peripheral retina in the deviating eye. So we want to prevent diplopia. More commonly clinically seen is an alternating suppression, which is switching between the two eyes, and a non-alternating suppression. Non-alternating might also mean constant. You have a constant strabismus, so one eye is being fixated and the other eye is being suppressed. And constantly, when one eye is being suppressed, it leads to amblyopia. The types of suppression clinically are also characterized as facultative and again constant. In some textbooks, you see these terms, so that's why I use them. When there is deviation and you see suppression, that is facultative. This comes of relevance when you see patients of intermittent strabismus. So when they have intermittent strabismus, there is suppression when the eyes are deviating. But when the eyes are straight, they have high-grade steropsis. So this facultative suppression is also an adaptation. When you see when the eyes are deviated, there is no steropsis. And when the eyes are straight, there is high-grade steropsis. We also need to understand that we are talking about corresponding retinal points. So by corresponding, we mean that, for example, we see two hands here, and the two fingers are corresponding to each other. If in any case, the two hands are not seen corresponding, this is also relevant to the retina. When we see the two images which are corresponding, stimulating corresponding retinal points, we normally have a normal retinal correspondence. So a normal retinal corresponding means that one object forming two images at two true anatomic foveas, that is stimulating the same point in the cortex, so known as a normal retinal correspondence. By anomalous retinal correspondence, we mean that fovea of one eye, for example, in this photograph that you can see, the right eye is normal, the left eye is inturned. So fovea of one eye starts corresponding to a peripheral point in the other eye. So this P, that is the pseudofovea that you see. The fovea of one eye is now having the same visual direction as this pseudofovea, this point on the strabismic eye. So this point, the brain sees it as the fovea. So it's a pseudofovea because anatomically it is not true, but it is a pseudofovea because it is corresponding to the fovea of the other eye. So what happens is that this peripheral point is now the new functional fovea, and the dominant eye, the other eye, keeps on fixating at the fovea. So it will not give the patient a binocular vision. It will just superimpose so that the patient is not seeing double, but actually there is no fusion and there is no binocular vision. Some binocular cooperation is kind of established besides having the strabismus. So the eye is squinting, but the brain is not suppressing it. The brain is using an extra foveal point to stimulate the same point as the fovea. So ARC is not eccentric because a lot of residents often ask that is eccentric fixation the same as ARC, but they are totally different. So for abnormal retinal correspondence, what happens is it's a binocular state. So one eye, for example, in this photograph, the right eye is normal, the left eye is deviated inwards, but the brain kind of the fovea of one eye is corresponding to a pseudofovea of the other eye. So what happens is once you close one eye, this eye will move and the fovea will start getting fixated. But once you remove the cover, the eye will go back. So the eye has the potential to fixate with the central point, but is choosing not to. Vis-a-vis, say, eccentric fixation. So even if you cover one eye, the other eye will keep on seeing eccentrically. It will not fixate centrally as the case of an ARC. So clinically, why is it important to understand ARC? So any long-standing strabismus that you see, the patient might have abnormal retinal correspondence, which can be easily checked by putting prisms in front of the deviating eye. If the patient starts seeing double with the prisms, that is known as a paradoxical diplopia, and there are quite high chances that once you operate on these patients, post-operatively, they will also complain of diplopia. So this paradoxical diplopia occurs in patients who have abnormal retinal correspondence. The only way to find out is by giving them a prism adaptation. You see a patient of long-standing strabismus and is not complaining of diplopia, try putting prisms in front of the deviating eye. And if the patient starts complaining of diplopia, because now the patient is thinking that the true fovea is actually not true. So they start complaining of diplopia, and this kind of diplopia somehow persists, say 4 to 6 weeks after surgery also. Of course, you can quickly check it because once the patient is viewing monocularly, it disappears. So abnormal retinal correspondence is only a binocular phenomena, and you'll hear more about this, I think, in the future lectures. Another important adaptation that a visually immature system has is a monofixation syndrome. So monofixation syndrome was given by Parkes, where he defined it as an entity seen only in small angle strabismus, say less than 10 prism diopter. So it's a peculiar kind of adaptation which occurs because the binocular fusion of the peripheral retinas is normal. The central field is kind of suppressed. So these patients have fusion, but low-grade stereopsis, and you'll see that they have a small esotropia. But once you start doing the cover-uncover test, then there is a larger esophoria. So patients with monofixation syndrome can also have amblyopia, but only of a mild kind. I'll just talk about it in a slide, in a coming slide when we talk about testing. So I know it is very theoretical that we have talked about how binocular vision has developed, but in order to test it, we have to kind of dissociate the two eyes. We kind of do the opposite of what the brain is trying to do. So this sensory evaluation of binocular vision, we should always do it before the motor evaluation, because as you examine the patient, you kind of dissociate the true eyes by your cover testing, by putting prisms. So always test the sensory, always do the sensory evaluation before you have moved on to the motor evaluation. So we want to establish all these concepts that I just said. We have to establish the presence of diplopia. We want to know if there is a suppression, if there is an amblyopia. And of course, we want to establish, once we have decided to do surgery in a patient, whether the patient is having an anomalous retinal correspondence or not. And then last but not the least, we want to check whether they have stereopsis. There are a lot of tests for testing every grade of binocular vision. Grade 1 being simultaneous perception, grade 2 fusion, and grade 3 stereopsis, which is the highest grade of binocular vision. A brief outlook on all the tests, only because we have understood the concepts now. All these tests are based on two broad principles, that is, one, diplopia, and second is the haploscopic principle. So by diplopia principle, you mean any test which is giving you one target and is trying to dissociate the two eyes by the use of red-green glasses is based on diplopia principle. So one target and red-green glasses, what are the tests that you use? The Wirtz 4 dot, the Bagolini, the red filter, the Maddox rod. So they are all based on diplopia principle. Now, the two eyes are being used simultaneously, but for testing binocular vision, you don't want the two eyes to be used simultaneously. That is, you are dissociating by the use of red-green glasses and giving one target at the same time. For haploscopic principles, you try to give two targets, one for each eye, and the targets can be moved. Now you dissociate the two eyes with the help of a mirror or with the help of glasses. And the tests that we have based on this principle include the synaptophore, the after image test, and the Lancaster red-green test. When you're testing binocular vision, you want to actually break the binocular fusion. So the more you break it, the better chances are that you will be able to test the binocular vision. So we talk about these tests as being the most dissociating to the least dissociating, and this is how you find them. The Bagolini striated glasses are just glasses put in front of two eyes with crisscross lines at 90 degrees to each other. So they are considered to be the least dissociating. If you just put an occluder in front of one eye, that is actually the most dissociating test. So you put one occluder, that is the maximum dissociation because you are kind of breaking all kinds of fusion. But for testing, Wirtz 4 dot test with the lights off is practically very, very dissociating. So a word about the Wirtz 4 dot test. So what are we wanting to look at? We want to know whether the two eyes are being used simultaneously or not. So you see these charts with your Snellen's chart in most of the clinics seen as 4 lights, one wedge, 2 green and 1 white light. If you look at from the left, the green side of the glass, you see 3 dots. And if you look at the red, you see 2 dots. So 2 red and 3 green. So patient wears the red-green glasses. We have dissociated the two eyes. And now you make them see the 4 lights on the light box. For distance, there are usually 4 lights, but if you're using a Wirtz 4 dot for near, there are 3. So that's actually known as a Wirtz 4 torch flashlight test. And you can do it with room lights on also and off also. But if you have them off, there are no peripheral clues. So it can be a very strongly dissociating test. So you practically do it at 2 distances, the 6 meter and at 33 centimeter. And you put red, green, and you try to ask the patient how many lights you are seeing, what color lights are they seeing, and how are they located. These 3 questions are the most important. So you see this is being done at distance, and this is how a near torchlight looks like. And we should always do these tests with the optimal correction of the patient, that is, make them wear their glasses and then over the glasses use the red green. So a normal response is something like this. You see 4 lights and you kind of fight for the 4th light. So a patient who has both eyes normally aligned will see 4 lights, but the color of the 4th light might be different. Sometimes red, sometimes green. Is that what the patient describes it? If you have the right eye dominant or the left eye being suppressed, so you will not see from the left eye and you will just see 2 red dots. If you have a right suppression, that is, you're seeing only from the left eye, you'll see 3 green dots. And a patient of diplopia will complain that the patient sees 5 dots. 2 red and 3 green. So again, just revising so that we have a clinical example that we can understand better. You do it at 6 meters, you do it at near, you show 4 lights, and then you ask the patient how many lights they see and what color they see. It is important to understand that distance and near Worth-4 dot might be important because a Worth-4 dot test done at distance will subtend a smaller angle at the eye, and at near would subtend a larger angle at the eye. This comes to relevance when we're talking about monofixation, which I will just explain in a bit. So just a clinical example, a 7-year-old male patient who has almost equal vision in both eyes, and left eye esotropia, and you see on covering the right eye, this patient has left ESO, the left eye moves outward to take fixation, and you see that he's mostly maintaining fixation with the right eye. So you diagnose him as a case of left constant esotropia, and you give him the red-green glasses to wear. He's mostly fixating from the right eye, so as we can understand that he would see just 2 red dots and he would suppress the image of the left eye. So large suppression of the left eye, there is no fusion. That is what your interpretation would be. A patient of exophoria. So this patient having 6/6 vision in both eyes, you see that he's using both eyes to fixate. He's a patient of exophoria. So sometimes he's fixating from the right, from the left, but most of the time he's fusing. So once you do the Worth-4 dot test, a fusing patient will give you the response that he sees 4 dots. But this patient, if you break the fusion somehow, that we did a patching of one eye for 1 hour, he got dissociated and he was squinting with the left eye. So his response on the same test at distance was that he now sees 2 reds. So doing it at distance and near matters, and the time of the day or the time of examination that you do also matters. Sometimes you are running the Worth-4 dot test as a first test, the response might be normal, and as you are tiring the patient out, the response might be abnormal. The third case I've just put because I wanted to highlight an important point that this patient is having an inward deviation and is having also face turned to the right. So he had left esotropia on the Worth-4 dot test that he saw 4 dots. So this somehow doesn't seem to match in a patient with strabismus and who is saying that he sees normal 4 dots. So what was wrong with this case? What we did was that we kind of, realigned the patient's head posture. You see now the patient's head is straight. So now he's not fixating from the left eye, but only from the right eye, and his response changed. So it is also important that you correct the head posture anomaly that the patient might have before you run the Worth-4 dot test. Distance Worth-4 dot test and near Worth-4 dot test are important because when you have a patient of monofixation syndrome, you have a central scotoma. So when you do a distance Worth-4 dot test, they would suppress image of one eye. For example, in this patient is seeing only from one eye. And once you do the Worth-4 dot test at near, you will see that they give a normal response because the peripheral field is normal. So this is what kind of is conclusive for the diagnosis of monofixation syndrome. Again, Bagolini lenses, they have fine striations that we talked about running in parallel in one meridian, one at 135, the other at 45, and you make the patient fixate at a small light. It is very less dissociating because there's a lot of peripheral binocular view, but the interpretation is relatively the same on the same lines. An orthotropic patient will perceive a cross. A heterotropia, say example in this one, a left suppression will see only from the right eye. A monofixation will have a central small scotoma from one eye. A patient having diplopia will perceive the image not as a cross but as a V or as an A. Again, esotropia, uncrossed diplopia will perceive the image as a V. Exo, cross diplopia, the image would be seen as an A. So I just spoke about these two tests because these two are kind of important to understand the binocular visual development, and I'm sure our seniors would cover the other tests in much greater detail. Just a mention of two unusual adaptations, that is horror fusionalis. So it's a very rare strabismic condition, but it is important because we need to understand that ultimately everything is happening at the cortical level. So somehow an inability to fuse and suppressed. So the patient has intractable diplopia because of some cortical problem, mostly related to trauma that causes horror fusionalis. Very rarely you can have adults who have had strabismus and they kind of lose vision in the dominant eye because of, say, a traumatic cataract. So for their life, they have been using one eye and that eye has a trauma. So they start seeing from the other non-dominant eye. If you don't treat, say, the trauma of the dominant eye, so it is no longer suppressed. The other eye also starts sharing the dominance. And once you remove their cataract, they now start complaining of diplopia. It is on the similar lines, we have a condition that is central fusional disruption. Again, with severe cortical damage from head trauma, you can lose the binocular fusion potential, and strabismus surgery in these patients would actually be detrimental because they will never be able to fuse and you might have to undo the strabismus surgery also. We are talking about binocular vision and fusion, and I just wanted to finish by telling us that there are certain monoocular cues also. A one-eyed patient does not necessarily not have depth. So once, in order to understand it, there are a lot of cues and sometimes we get confused as what do these cues mean. In simple terms, if you're sitting in a train and you try to look at the trees outside, even if you have one eye, you know that the larger tree is nearer to you and the smaller one is farther apart. So even if the patient is, has lost one eye or is one-eyed, they will have some cues which will help them to give depth. So stereopsis is, relatively for a shorter visual distance, and some depth perception can occur without stereoacuity as well. To sum it up, we want to, if you want to have sensory fusion, we want to excite the corresponding retinal elements. For that, we need to see simultaneously from two eyes, we need to fuse them, and then we need to interpret them as normal. And motor fusion is ability to align the eyes in such a manner that sensory fusion can be maintained. I think I'll just acknowledge my team at PGI for this presentation. Thank you, Dr. Pradeep and Dr. Santosh, for giving me this opportunity. And I'll stop sharing my screen.
Thank you so much, Dr. Savleen. Dr. Pradeep Sharma, sir, do you have any comments before we proceed for the questions?
I think it was a wonderful presentation by Dr. Savleen on a topic which is little difficult to understand, and I'm sure most of the people would have got the grasp of the conditions which are there. So what she was trying to explain was the situation of anomalous retinal correspondence. Sometimes I give an analogy like between two nations. If there has to be a correspondence, it will be between the two heads of governments, like PM to PM level, the fovea to fovea level. That is the normal binocular correspondence between two nations. But suppose one of the prime minister is not well or is not able to communicate, then he can delegate the authority to his foreign minister, who may now correspond with the prime minister of the other country. So this will be a situation like an anomalous retinal correspondence. There is still a correspondence established. Otherwise, it would be a situation when the two nations do not communicate. So here there will be a communication between the two nations, but it will be not as per the protocol. So this will be an abnormal or anomalous correspondence between the two nations, the FM and the PM level. But whenever the FM comes back to his own nation, then the PM takes over. So he doesn't give the full authority. It is only for that particular situation under binocular situation. So what you are trying to explain, ARC is only under binocular situation. The moment you give them the monocular status, then the fovea takes over. The fovea will still have the straight ahead gaze, the central fixation, and the ARC point is not having any straight ahead gaze. Unless there is a situation in which the other point, which was now corresponding most of the times, it becomes so strong that it takes over the function of the fovea. Then it becomes like an eccentric fixation. So an ARC is a situation which is only under binocular situations, whereas an eccentric fixation is under monocular conditions. The extrafoveal point is so strong, like doing a coup. So he takes over all the functions of the prime minister because he has got the strength to do it. So understand that difference between the ARC and eccentric fixation, as I would like, to give an analogy to make it simple.
Very nicely explained, sir.
Dr. Amitava, sir, any quick comment from you? So you're muted, sir.
I think you're muted, Amitava.
No. Professor Pradeep Sharma has put it so succinctly and so well that it's difficult to come up so anything better.
All right, sir. Then I'll proceed with the questions. What is the difference between harmonious and non-harmonious retinal correspondence?
So I kind of left it out because I thought the next lecture was going to be on anomalous retinal correspondence. Just to brief you about it, it's a difference between the objective and the subjective measurement of the retinal correspondence that you have. So like sir said, you have, say, the fovea of one eye and you have the extrafoveal point. If the amount of degree of strabismus is kind of corresponding both objectively and subjectively, that is what is harmonious. And if they do not seem to correspond, that is unharmonious. So you can test it on synaptophore, or you can test it by testing the deviation by prisms. And if they do match, like the patient is also perceiving the same amount of strabismus that you are measuring, so that is known as a harmonious ARC. I think it can be explained better on a diagram, or maybe more in detail when we discuss anomalous retinal correspondence.
Yeah, basically what Savleen is saying is that there is something which is the difference in the deviation, that is the angle of anomaly, the distance between the fovea and the extrafoveal point. If it can be fully at the sensory level, accommodated for or adapted for, that means the extrafoveal point nerve takes over the full correspondence, then it is an harmonious situation. Then it is called the harmonious ARC. Whereas if it is in between, that means there is still an angle of anomaly left. So an unharmonious is in a way a stage in between the full harmony and the situation in which there is no ARC.
How do we decide which test of stereopsis is to be performed in a given child?
I think we've not been talking of stereopsis tests today. So maybe this question may come up. We can hold this question when we have actually talked about the tests for stereopsis in a future lecture. So, it may not be proper because we haven't talked about the tests of stereopsis, both for distance and near, and there are several of them actually.
Next one is an evaluation of squint. Is sensory examination performed prior to motor examination?
I think I just highlighted that it's always better to perform. Normally in the flow of patients, sometimes we teach the residents, and that's what we start doing once we have a patient with strabismus. But after history, that's what I like to tell the residents, that once you have a history and something is going on for quite some time, it is always it will give you more and better and accurate assessment if you do the sensory testing first, because your results will be altered. You might have to, if you do the motor exam and then you find it's not matching with the sensory, you might have to call the patient again for a sensory evaluation. So if you have a history of say a constant or even an intermittent strabismus, and more important, I think, for an intermittent, and then you are you're going to evaluate the patient, just sensory examination doing before the motor is always more valuable.
I do want to say that while doing the sensory evaluation, you should allow I want to point this out to the residents, that they need to allow the patient to adopt the head posture which is there, and to use the least dissociative test, so that you can get again all the positive. And Bagolini is one of my favorites. So if you get because once you break the fusion, there could be situations where the patient may not be able to regain it while he is in your clinic.
I think Dr. Savleen had shown one case. I think people should remember when the person was having an concomitant strabismus, and when he was having the head posture, then he gave a binocular response on the word foot dot test. But the moment you corrected the head posture, and then he was then having an incompetence, the esotropia was showing up. Maybe it was a case of Duane's retraction syndrome. So in that situation, then in that he may have a either a diplopia response or maybe a suppression. So then he may not give a binocular response.
I think related to this, can you please explain the difference between confusion versus diplopia once again?
So simple 2 points. Diplopia, that means that you are seeing one object as double, and confusion, that you're seeing two objects simultaneously. So even if you don't remember the corresponding retinal points, part, that is okay. But just that one image is seen as double. So one object you see as two, so that is diplopia, and you see two different objects simultaneously. That is confusion.
In fact, I think the difference is very clear. When the two foveas in a situation of misalignment are seeing two different objects, that is confusion. The two foveas are supposed to be seeing the same object if the eyes are aligned. But if they are misaligned, then the two foveas would be seeing two different objects because the principal directions are going to have different perceptions. So that is confusion. But if we are talking of diplopia, it's because of the same object striking on two disparate points, non-corresponding points, because of the misalignment again. Because the eyes are not aligned, now the corresponding points are not going to be stimulated by the same objects. One will be stimulating the fovea of one eye, and the other eye, it will be stimulating some other point because it is misaligned, it cannot be fovea. Just understand that. So it will be a disparate points. And so diplopia is always between fovea and some extra foveal point. Whereas confusion is always the viewing of the two foveas in a situation of misalignment.
Shefali, what I tell the newer PGs who join, and because it can be very confusing, and I tell them, look, if my left eye fovea is looking at, say, student A with my fovea, and my right eye is esotropic, and the student's image is falling on a non-foveal point, and then I tell them if my eyes could speak on their own, and I would ask my left eye, the one which has got the fovea in alignment, where is that student sitting? The left eye will say she's sitting in front because the fovea is the front facing direction in that point. And if you ask my right eye, and if my right eye could speak, then my right eye would say that the student is sitting to the right of my front direction. And then if you ask my brain, then I would say there are two students. One is sitting in front. That's what my left eye told my brain. And one is sitting to the right. And that's why they have diplopia. And a similar story, if you just change the question, is what is in front of you? The left eye will say student A, and the right eye, which is deviated, will say what is in front, who is in front, student B. And if you ask the brain who is in front, and there's actually two of them are in front, they're overlapping. And that's confusion.
Makes it clear, sir. Thank you. Another one is, what are some quick tests to identify suppression in OPD? Any quick tests that we can do to identify suppression in OPD? Am I audible?
Yeah, we can carry on.
Yes.
What 4-dot test she had described, the Bogolny test she had described, basically both of these are giving two different levels of dissociation. So if you put Bogolny glasses in front of the two eyes, if both eyes are in alignment, then you will see a cross response. Mind you, if there is a misalignment, there can be two options for the Bogolny. It may be it may be still a cross response if there is a ARC, harmonious ARC. So in the presence of an harmonious ARC, you may still see a cross response in spite of misalignment. So whenever you're using a Bogolny glasses, ask the person first whether he's seeing a cross response. Then you have to do another thing, that you have to do a cover test and see if there was a manifest squint at that moment of time or not. If the two eyes were still having no manifest squint, then only we say, okay, it is a normal retinal correspondence. Otherwise, there can be an harmonious ARC also, which can give rise to a cross response. So one test is the Bogolny glasses. The second test, which she described, was the Word 4-dot test, which can also be used for testing suppression. I mean, the right eye suppressing, left eye suppressing. She clearly showed that if the red filter is being used over the right eye, you'll see the two red lights, and the green filter over the left eye, you see the three green lights. So if you see not 4, but either 2 or 3, it indicates that one of the eyes is showing suppression. There are other tests also, of course, which you can use, but these are the two common ones. On Synoptophore, again, you can have the slides for suppression, which will differentiate. And then you can have the Polaroid glasses also to use.
We have the after image test also, which is very nice interpretation. But in the OPD, I would say Word 4-dot is mostly there in most of our Snellen charts. So it's a very quick test and very reliable. I mean, it's easier to understand. The after image also, if you have, say, a direct ophthalmoscope or a torchlight, and if you want to do it, you can do it in the OPD. But interpretation wise, asking the patient might be difficult because they might not be able to tell that well. So words for dot with red, green is my favorite to do.
But as I think Dr. Amitava said, Bagolini is the best because we give you the actual situation. Mind you, when we are testing, dissociation is only like tagging the two eyes. We want to know what the right eye is seeing and what the left eye is seeing. And that is the reason for using either the red and green glasses or the two haploscopic tubes, or in the Bagolini, we are creating these striated lines, which will convert the spot into a line, an oblique line in the right eye in one direction, in the left eye the other direction. So basically dissociation is only tagging the two eyes, just to let us know which image is belonging to the right eye and what the left eye is seeing. So unless we tag, we won't know. The person will be seeing binocularly, all right. So normal situations we are seeing with both the eyes, that is the most physiological one. But just to let the examiner know, we need to introduce some amount of artifact. And the least artifact is the Bagolini, because here only the light source has been altered. The rest of the field is going to be the same for both the eyes, and that's why it's the most physiological test. In the case of the red and green, the entire field is changed. One eye is seeing the red image, the other is seeing the green image for each and every field thing. So it is more dissociating. And the after image actually is the most dissociating because there the entire image is dark, entire field is dark. Only the light sources are different for the right and the left eye. You're keeping it horizontal or vertical. So that's why it's the most dissociating. It's just the opposite of Bagolini. If you just understand, it's one end of the spectrum and the after images are the other end of the spectrum. So they are the most dissociating.
So there's one more point I want to say is that see nowadays the phones also have these apps, so you can have those worth 4 dots right in your hand for a little test. You do need red green goggles, but I also encourage my students to smear they carry a spare spectacle and smear an ointment, preferably not atropine, across, and those linear striations of smearing also cause a pretty good Bagolini effect. And if they use just an ophthalmoscope also, and they make really lovely crosses, and they can do that pretty much anywhere they want. And I tell them, you need to do these things. I mean, you don't have to, even walk across somewhere else, or if you happen to be in a place where you don't have these things, you can always do these little tricks to enjoy binocularity and the lack of it.
Can you please explain the Parkes monofixation syndrome?
So, monofixation syndrome, I want me to go back to the slide and do it, sir, or should I?
Ma'am, you can share the slide, no problem. If it makes
it just for a moment, I think the dot test that we saw pretty much explains what is a monofixation syndrome. So monofixation was actually, described for a very small esotropia that we have. It's mostly less than, say, 10 prism diopters. I'm sorry, I'm running a little faster. So it's, you have the binocular fusion of the peripheral retina, but the central field has a scotoma. So the deviating eye with an esotropia, about 10 prism diopters, it will suppress and cause a central field scotoma. So peripherally, you are fusing, but there is a central scotoma. So you see there's a small esotropia, you suspect monofixation, then you have a small esotropia, and then you do alternate cover test, and then you find a large esophoria. So it's also known as the phoriatropia syndrome, because of this particular finding. You see a small esotropia, and then you do alternate cover test, you see a larger esophoriatropia, and then once you start asking them on the words for dot test, they'll be giving a different response for distance and near. Because of the central field, there's a central scotoma, and the peripheral field is normal. So normal response from the peripheral retina and suppression from the central field. So that is what is monofixation.
Basically, monofixation syndrome is a type of microtropia. So when Parkes had described the term microtropia had not been coined. So he described it as monofixation syndrome, implying that the two eyes are having a situation, although they have a binocular fusion, they are having a monofixation. The central point is having only one eye seeing and the other eye is having a central suppression. So that is what is a type of microtropia in which there is a central suppression scotoma. And you may have a situation of microtropia with identity or without identity. So again, I mean, these things will have probably more so in the coming lectures. So it's one type of microtropia, which means that by definition, it has to be 8 prisms or less esotropia. And when we are testing binocularly, there will be a central scotoma. So these people will not be able to see the two images, the Bagolni glasses images as full cross, but having a central scotoma. And when we do the microtropia test with 4 prism diopter test, 4 prism base out diopter test, again, you can easily distinguish a monofixation. Then you'll see that one eye moves and the other eye doesn't move, or there is no recovery movement. So probably if there is any still a requirement, we may have this slide presented someday and show to the people if what does it mean, or we can have a clinical way of testing it and showing when we use the 4 prism base out test that distinguishes a monofixation and the other microtropias along with it.
The last one for the evening. If there is ARC present, what happens after squint correction?
So if there is an abnormal retinal correspondence, in simple terms, if you correct it, now as sir said, the fovea is corresponding to a non-foveal point. Now you're trying to align the eyes so that the fovea is now corresponding to the fovea. So now the patient will start seeing double. So as one PM has gone away, so the other PM is given the charge to somebody else, and now he's come back. So it'll take some time, but yes, he will understand all that has happened, and the patient will start fusing, say after 4 to 6 weeks is the normal time.
There may be a paradoxic diplopia, but actually speaking, if there is an harmonious ARC, why would you do a squint selfie? So these are so small angles, usually 8 prisms or maybe maximum 15 prisms. Sometimes we have. But if that is the situation, cosmetically, they are not having any problem. And binocularly, they are seeing with ARC harmoniously. So why would you do anything? The sensory adaptation has already done the job. So the strabismus surgeon doesn't need to intervene in a situation when there is an harmonious ARC. And if he does, he will have to pay the price for it and have a paradoxic diplopia.
I think with this, I wrap up the questions. Thank you so much, Dr. Savleen ma'am, and for all the inputs, Dr. Pradeep Sharma sir and Dr. Amitava sir. Any parting thoughts from the discussants and speaker?
I think it's been a wonderful session, and these terms like facultative, obligatory, we should keep in mind. And that is how we have certain times that we have a situation, we have a hangover of it. Facultative is that which doesn't have a hangover, and obligatory is continuing a hangover which goes on in suppression in the form of amblyopia, and in an ARC the hangover goes on in the form of eccentric fixation. So these are the hangovers which we should avoid. So thank you, Dr. Savleen, thank you, Dr. Amitava, and thank you, Dr. Shefali, for moderating it very nicely.
Thank you, sir.
In another enjoyable session. Yes.
We'll all meet on July 22nd for our next lecture, which is Anomalous Correspondence by Dr. Kavita, which will be this Friday. So see you all on Friday evening.
Good night.
Good night. Good night.
Thank you.